everyone.
Can we have Dr. Juhi over here in the next
Hello everyone.
podium?
My topic of presentation is Torpedo Maculopathy, diving deep in search for a newer classification system. This would be my flow of presentation. So torpedo maculopathy is a rare congenital anomaly of RPE involving temporal age of the macula, which is often diagnosed incidentally. It was first described by Roseman and Gass in 1992, later on termed as torpedo maculopathy by M.J. Daly in 1993. The aims of our study are descriptive analysis of multimodal imaging of torpedo lesions and formulation of a novel SDOCT-based classification system. This is a retrospective observational study comprising of 15 patients with torpedo lesion at a tertiary care ophthalmic institution in southern India over past 6 years. We have reviewed all the medical records and the clinical data including fundus imaging, OCT imaging and autofluorescence. This is a representative case 1. There is a hypopigmented flat stellate lesion can be seen temporal to the fovea. On the SDOCT there is IZ and EZ disruption with intact inner retina and absence of outer retinal cavitation defect. On fundus autofluorescence, central hypoautofluorescence with bordered hyperautofluorescence can be seen. In another case, there is a hypopigmented flat stellate lesion can be seen with a hyperpigmented margin. In the SDOCT, there is IZ-EZ disruption, but with a shallow outer retinal cavitation defect and a focal choroidal excavation. On the fundus autofluorescence, there is central hypo-AF with hyper-AF borders, with stippled hyper-AF within the lesion can also be seen. So coming to our results, the average age of our study was 37 years, ranging from 4 to 68 years. The laterality and the gender was insignificant, and majority of the patients had a BCV of 20/20. 4 patients had a dimness of vision. These are ocular associations we could have seen: high myopia, POAG, optic disc in the other eye, NPDR, branched retinal occlusion, congenital ptosis, etc. On fundoscopic analysis, all the lesions were temporal to fovea. 10 out of 15 lesions were stellate in nature. 4 out of 15 lesions involved partly or complete of the subfoveal region, and 3 lesions were outside macular region. On autofluorescence analysis, all the lesions contained a hypoautofluorescent central area with hyperautofluorescent borders. But 8 out of 15 patients showed stippled hyperautofluorescence within the central hypoautofluorescent area. On SDOCT, 7 patients did not have any outer retinal cavitation. Majority of the lesions presented with EZ and IZ disruption. 3 patients had inner retinal thinning associated with outer cavitary defect, and 9 patients demonstrated sublesional pachyvessels. ONL thinning was seen in all cases associated with outer cavitary defect, but in 57.14% patients in absence of cavitary defect. Focal choroidal excavation was seen in 3 patients. We had 2 cases where double torpedo lesions could be seen, and 1 case where along with the torpedo lesion there was ONL cystoid cavity was there. So what did we learn? Although classically described as a hypopigmented lesion in ophthalmic literature, areas of hyperpigmented patch could be seen. Stippled hyperautofluorescence within the lesion corresponds to the photoreceptor outer segment elongation on the under surface of the neurosensory retina. It is associated with outer nuclear layer thinning also could be seen, and focal choroidal excavation and inner retinal thinning could be found individually, together coexisting with outer retinal cavitation. Based on this, we have proposed a OCT-based modified classification. There will be broadly 2 types, type 1 and type 2. Type 1 is absence of outer retinal cavitation on OCT with EZ and IZ disruption. Type 2 is subdivided into 4 types. Type 2A, where outer retinal cavitation defect will be there without any inner retinal thinning or focal choroidal excavation. Type 2B with inner retinal thinning but without focal choroidal excavation. Type 2C with focal choroidal excavation but without any inner retinal thinning. And type 2D is a mixed type where both can be seen. Coming to the discussion, so till date the largest data set was 13 patients described by Golchet et al. In 2009, but there was no SDOCT based classification or anything. By Wong et al. In 2015 published the first novel OCT based classification system on 5 patients, were broadly categorized under category A and category B. By Tripathi et al. In 2018, a third variant was added in a single case documentation. Recently in 2020, Venkatesh R et al. Published their case series with 9 patients. So coming to the conclusion, this is the largest data set on torpedo maculopathy in ophthalmic literature presented till date. Novel OCT-based characteristics like ONL thinning or presence of pachyvessels associated with torpedo lesion is described for the first time in ophthalmic literature. A novel SD-OCT-based classification system has been developed based on detailed analysis. And as 3 of our cases have been seen outside the macular region, we propose the terminology should be changed to torpedo retinopathy. These are my references. Thank you.
Avik,
Yes, sir.
very good presentation. But there is considerable overlap between, and considering this very high number that you are seeing torpedo maculopathies, very rare to find.
Yes, sir.
But it's a tertiary center, I can imagine. But there is a considerable overlap between acquired toxoplasma scars, amniotic nevus, and various other scars, histoplasmosis, considerable overlap. So, how could you definitely, there are some parameters which says that this is torpedo maculopathy?
Sir, usually when torpedo maculopathy initially was described, that was on temporal bulge, that it should be on the temporal, just on the junction of the temporal arcade where it is finishing. But later on when we saw and those OCT characteristics we have seen, in the Wong et al. Classification, they have described the type 1 and type 2. Over there the OCT features and our OCT features in these cases, we have seen in the toxo cases or in the other chorioretinal atrophic cases, the OCT characteristic is not this similar. Over there the inner retinal changes are way more than the retinal thinning is quite prominent in the compared to this torpedo cases. In torpedo cases, the basic pathogenesis lies in the choriocapillaris layer. So usually the IZ-DZ layer usually gets disrupted along with most majorly outer retina. Very minimally inner retinal thinning can happen, but inner retinal disruption usually never been seen. 1 or 2 cases very rarely seen, but in that case also the texture of the lesion, the hypopigmented patch of the lesion is very different from the toxo lesions that we
Any
use.
new vascularization?
Sorry, sir?
Any new vascularization?
Sir, actually one of my case recently, when I sent it for this presentation, that time that neovascularization was not there, but that ONL cystoid cavity case actually finally developed CNVM later on.
There was cavitation in some cases.
Sir, one case only.
Right.
But that time, sir, when it was, we have shown the photo, that time we have done localized OCT and OCTA, but there was no neovascular complex was that time there. But right now, we could see some neovascular complex generating.
No fluid was seen in any.
Otherwise, sir, SRF, sir, actually fluid cavitation is there.
Right.
So overall, there is a SRD kind of picture is there, but no fluid as such we have seen in those cases. That one case actually we have done FFA, but no leakage was seen.
Thank you.
Thank you, sir.
Thank you.